Well, first of all, I'd like to thank you for the kind invitation to be here. It's my first time in Israel. It looks like a beautiful city. My task is to talk about the history of metabolic surgery. It's kind of a difficult topic. I have no disclosure. I think I need to mention this guy who maybe did not invent metabolic surgery, but certainly contributed to the definition of the term as an operative manipulation of a normal organ system to obtain a biological, potentially healthy effect. And there are a number of examples of operations that fit within this definition. And certainly our surgeries today do. I could have done like he does usually when he gives a talk about the history of metabolic surgery, go through all the surgeons and all the operations that have been done over time, have come up, have gone because they failed or they were related with complications. I'm sorry, it goes by itself. I decided I'd try to go through a number of landmarks in the pure history of metabolic surgery for type 2 diabetes. And in fact, the first observation that gastric surgery improves diabetes dates back a good 60 years ago when these guys, Friedman and all, noticed that after subtotal gastrectomy, diabetes improved, even though it was certainly not the primary intention of the surgeons at the time. And a number of other observations of the same kind have been published in the 60s. And that was way before the first big papers on the results of bariatric surgery and positive effects of diabetes were published mostly in the 90s. And I think the landmark paper is certainly the one from Walter Porres in 95, when he showed that gastric bypass improves diabetes very much, and in fact, very soon after the procedure, even before weight loss occurs, with 83% of the patients achieving remission of diabetes, and the percentage is even higher if you take all the patients with impaired glucose metabolism. That led to a paper in the Lancet at 2001. Should surgeons treat diabetes in severely obese patients? And a number of remarks here. Poorly controlled diabetes remains a devastating disease. We all know this. Obesity surgery can improve glycemic control and occasionally lead to remission in diabetes. But the risks of surgery should be set against the risks of doing nothing. The surgery may be the most appropriate treatment for selected patients, and there was already at this time an urgent need for controlled trials to identify the best indications, procedures, and patients for surgery. Henry Buchwald published in 2009 the meta-analysis of all the published studies showing that yes, bariatric surgery improves diabetes in a number of patients. It's not the same after every procedure, but certainly a number of patients go into remission after surgery. Most studies in this review were not randomized controlled trials. They were relatively poor quality, but they all converged towards the same conclusion. So I think it's still important. So how does it work? I think that an enormous amount of work has been done and is still being done to identify the mechanisms involved in diabetes remission beyond weight loss. Of course, weight loss plays a role. We know that medical weight loss improves diabetes, and there's no reason why surgical weight loss would not improve diabetes. But it seems that there are other mechanisms associated with surgery that help putting patients in remission. And one of the first authors that looked deeply into this was Francesco Rubino, who believed in this so-called incretin, anti-incretin imbalance within the digestive tract, suggesting that in diabetes, in type 2 diabetics, the anti-incretin were stronger than in the incretins. And he studied specifically gastric bypass and was able to show that, yes, GLP-1 and other hormones increased after gastric bypass. And there were a number of theories 15 years ago, mostly two theories, the so-called Foga theory, that says that the exclusion of duodenum from the digestive tract results in the inhibition, often yet unknown signals, still in 2018, responsible for insulin resistance and abnormal glycemic control in type 2 diabetes. And he showed that, yes, in diabetic rats, exclusion of the duodenum improves glycemic control, and it was also shown in humans by Ricardo Cohen later on. Much more recently, the group from François Patou and Lille showed that exclusion of the duodenum and proximal digestive tract plays a role in glucose absorption, and did a very nice study in pigs where they put clamps on the digestive tract before the anastomosis at the base of the Y loop after gastric bypass, or even further down, showing that, I don't know if I have more, moves from slide, that if you clamp here and you measure glucose in the blood, placing a mirror here, glucose increases only slightly, whereas if you remove the clamp and you let the food content go further down, then glucose increases a lot. And they were able to show that the addition of bile in the alimentary tract contributed to this higher absorption of glucose, and that is, in fact, the salt contained in the bile that helps this. And they were able to show that inhibiting this sodium glucose couldn't transfer to 1 in the intestine by adding fluorescein prevented this effect. So they show that gastric bypass basically reduces glucose absorption in diabetic patients. Oh, that was pigs, but they also showed it in human. Then there is the hindgut theory that says that faster arrival of food into the distal bowel increases the production of incretins. And this is based on the theory and well-known principle that in type 2 diabetes, the so-called incretin effect, that you produce more insulin after oral than IV administration of glucose, is blunted. And this is restored and has been nicely shown by many authors. This is a paper from Blandine Laferret from New York showing that post-surgery this incretin effect is fully restored, even though the glucose curve is not exactly the same as it should be in normal patients. Another important fact that is being studied nowadays, this increase in bile acids in the blood after bariatric surgery, and this is true for especially gastric bypass and sleeve gastrectomy. And it may be that the increased reabsorption of bile acids in the proximal digestive tract, especially the BP limb, plays a role in this. So there is certainly a role for weight loss, and this has been shown by a study by John Dixon in 60 diabetic patients. Light diabetes only present for 2 years, and they showed that patients who underwent a lab band lost more weight than controls, and they also achieved remission of diabetes much more often than controls. But the main finding in the study was that, in fact, the degree of weight loss and not the group itself or the method used to achieve it was the major driver of diabetes remission. So there are different factors involved in diabetes remission. I don't have time to go through all of them. Surgical interventions to treat severe obesity have a profound effect on glucose metabolism, weight loss is associated with improvement of diabetes, and several mechanisms are likely to play a role. And this led to the convention by Francesco Rumino and a number of others of the first Diabetes Surgery Summit in Rome in 2007, where they concluded that we needed collaboration, that gastrointestinal surgery could be used, that we needed good quality randomized control trials, and that we need to work in a multidisciplinary fashion. A year later, the first World Congress on Interventional Therapies for Diabetes was held in New York with almost the same conclusions. There is a rule for gastrointestinal surgery, but it needs further investigation. In the meantime, several papers came out. This first match paper of patients treated for diabetes with either Roux-en-Y gastric bypass, medical therapy, or gastric banding, or even BPDDS, showing that surgery controls diabetes much better than medical therapy, both in terms of weight loss, but also control of A1C and reduction of the number of medications needed. Gastric bypass better than band, but not as good as the DS. You all know about the study by Schauer, the STAMPEDE trial, that showed that surgical therapy reduced diabetes, or resulted in remission of diabetes in many more patients than medical therapy, shown here, and also resulted in a reduction in the number of medications needed to achieve control. It also was related to greater weight loss than medical therapy. Same was shown by the study by Mingrone from Italy. I don't have time to go into the details, but the results are basically the same. Here comparing gastric bypass and BPD, showing that BPD is even more effective than gastric bypass. And there have been a number of meta-analyses or reviews of the different studies, all showing that overall surgery is much better than medical therapy to obtain remission from diabetes. And this one has just been shown before, showing basically the same, that overall surgery reduces the risk or improves the risk of remission by a high factor, and that gastric bypass is more effective than the band. The third World Congress was held in London in 2015 with review of all the available evidence, and that led to the algorithm that has been shown before, dividing patients with type 2 diabetes in obese or non-obese. Don't know whether a BMI of 29.9 is very different from a BMI of 30, but yet. And there's different ways to act with diabetes depending on the importance of obesity and the effectiveness of medical treatment. Well, we know that now that surgery results in remission of diabetes in about 70% of the patients with low BMI, that means below 35, and the percentage of remission rate is exactly the same in patients with high BMI. So why should BMI play a role in the decision process? I don't know. When to operate for established diabetes? Should you try medical therapy first and consider surgery if it fails? And then how long do we wait? Do we wait a long time? We know, I'm almost finished, we know from the SOS study that the sooner you operate on patients after the diagnosis of diabetes, the more remission you obtain and the longer the remission lasts. We also know from the same study where they studied vascular complications of diabetes, as surgery reduces complications, but again, the sooner you operate after diagnosis, here less than 1 year after diagnosis, then the influence of surgery is much higher than if you operate late. So metabolic surgery is now well established, should be considered an option in every patient with type 2 diabetes and BMI above 30. I think that the earlier one operates, the greater the chances to obtain remission. The earlier one operates, the longest the remission will be, and the earlier one operates, the less macro and microvascular complications with the cure. What about non-diabetics? We know that from the Swedish study, again, the operation has its largest effect in pre-diabetics. So here expressed as a graph, if you operate on pre-diabetics, you get an 82% risk reduction for vascular complications. So should we maybe also operate on pre-diabetics? I don't know. Well, looking forward for the 4th World Conference on Interventional Therapies for Type 2 Diabetes, where hopefully some of these questions will be answered. And I thank you for your attention.